My name is Brett McKelvey, and today we're going to be talking about end-tidal CO2 and capnography and its uses in EMS. The goals of today's class is we're going to know how and when to use various types of capnography devices. We're going to interpret what's happening with a particular patient's airway when shown a sample capnography waveform. You're going to be able to label the 4 different parts of a normal capnography waveform. And finally, you're going to be able to know what the patient's body is doing based on capnography values in the waveform. So what is end-tidal CO2 and capnography? End-tidal CO2 stands for end-tidal carbon dioxide. It's the amount of end-tidal CO2 in your exhaled air. Capnography is the actual graphical waveform. Capnometry is the numerical value, and it's always included in capnography. So what are the differences between end-tidal CO2 and your pulse oximetry? End-tidal CO2 measures ventilation, and your SpO2, your pulse oximetry, and measures oxygenation. So what are the differences between ventilation and respiration? Ventilation is the movement of air. It's designed to eliminate CO2 and to take in oxygen. And respiration is the exchange of gases at the alveolar level, what's happening in the lungs. So for us, a lot of the general uses for capnography that you're going to have is, first and foremost, in EMS, it's one of your best ways to know that your intubation's good. It's in the trachea instead of the esophagus. It's also good for monitoring vent and vent circuits for leaks. And you're able to help diagnose some clinical problems by looking at the waveform and the CO2 levels, such as hypoventilation, hyperventilation, bronchoconstriction, and others. So your device is used to measure end-tidal CO2. You have a capnography mask, it's like an honorary breather, and you also have a capnography nasal cannula. And then another use is a little device that slides on the tip of your endotracheal tube, and it'll measure your end-tidal CO2 as well. Right now there's 2 main ways of measuring, 2 types of the technology, the devices. One's called infrared spectroscopy, and the other is side stream sampling. Side stream sampling is like the older method. It draws a large sample into the machine from the line for analysis. Infrared spectroscopy, it's infrared sensors that detect and absorb the light, and then they calculate a value based on the value of the air that it sees. And it's able to determine your carbon dioxide value in the air, the samples. So how is end-tidal CO2 measured? There's capnometry and capnography. Under capnometry, there's 2 different ways. There's qualitative and quantitative. Qualitative is your color changing device, your quick cap, and that just is going to give you a yes or no answer. Your quantitative displays the value of the end-tidal CO2. And then capnography is going to include capnometry, so you're going to have that number, but it's also going to display a waveform, so it's more diagnostic. So this is a normal capnography waveform, and as you can see, there's 3 sides to it. Your first upslope is going to be your respiratory baseline, or the baseline is your respiratory baseline. It's when you're not exhaling at all. B is your expiratory upslope. As you start to blow off CO2, your CO2 levels rise. C is your expiratory plateau, and that's towards the end of your exhalation. Your end-tidal CO2 is not going to rise that much more. D is it's your actual end-tidal CO2 value. It's the highest end-tidal CO2 value of the waveform. And then E is your inspiratory downstroke. As you breathe in, your CO2 levels drop fast. So 3 common abnormal waveforms that we're going to talk about real quick is hypoventilation, hyperventilation, and bronchoconstriction. Hypoventilation, several things that can cause it: narcotic overdose, respiratory depression, brain injuries, oversedation, and then simply if you have your patient intubated and you're bagging for them, you're not bagging fast enough. Hyperventilation is caused by hyperventilation syndrome, anxiety, can be caused by pulmonary embolism and bag rotation too fast. Finally, bronchoconstriction is pretty common to see, caused by asthma, emphysema, COPD, your incomplete airway obstructions, or possibly a kinked endotracheal tube. So here's some animations of what's happening. Hyperventilation, as you can see, your end-tidal CO2 values raise with each breath over time. And that's about it, increasing levels of CO2 for your hypoventilation. Hyperventilation, you're going to see decreasing levels of carbon dioxide and tidal CO2. So it's just the opposite. And then finally, here on bronchoconstriction, you have this prolonged expiratory plateau. So it's like you have your baseline, and then it's hard for these patients to breathe out as well. So instead of their expiratory being sharp angled, it's more of they call it a shark fin as they start to exhale. And then they have no problem breathing in, so your inspiratory downstroke is still fast. So, what's happening to the body depending on the end-tidal CO2? As your end-tidal CO2 increases, your pH in your body is going to decrease. And as your end-tidal CO2 decreases, your pH increases. So it's just the opposite. Absence of CO2 can be caused by esophageal intubation and cardiopulmonary arrest. And then if you're doing CPR, and all of a sudden you see a sudden increase in end-tidal CO2, it's a good indication that your pulse is about to return as your body starts to circulate blood and release carbon dioxide. So anybody have any questions? No? Alright, we have a quick little assessment, and good luck. If you have any questions, just let me know.